Hi, and welcome back to the Robbins Headache Clinic YouTube channel. We're putting a series of talks and lectures about headache-related subjects. We've done refractory, difficult-to-treat headaches, psychological comorbidities, and this latest talk is what I call Deconstructing the Art of Headache Medicine. So medical comorbidities, whether people have high blood pressure or asthma, are very important. We look at fibromyalgia and other central sensitization syndromes. Fibromyalgia is widespread pain that technically for at least 3 months people have pain and tenderness, usually in the back and neck and arms or legs, big muscle groups with fibromyalgia with tenderness to touch. We might treat people differently who have other central sensitization syndromes like chronic pelvic pain or TMJ, TMD. Sleep is very important. We look at insomnia, early, middle, or late insomnia. Do people have sleep apnea? Increased risk for sleep apnea is more in men, more with advancing age, more overweight, and thick necks. We look at neck size actually, can almost predict some people, and we ask for snoring. So if somebody is a snorer with a thick neck, a little overweight, we're always on the lookout if they have high blood pressure, particularly for sleep apnea. We might send them for a sleep test, and that might influence the headaches. We look at the GI system, the irritable bowel syndrome. IBS or irritable bowel is what I consider a central sensitization syndrome. It's an inherited genetic condition, just like chronic migraines. And many people with chronic migraines have irritable bowel. Your whole GI system has its own nervous system. 93% of our serotonin is in the GI system, and it doesn't work quite right. So a lot of people have constipation or diarrhea or both. If it's irritable bowel constipation, there are a few new medicines for it, and we'll avoid certain medicines. If it's IBS-D, irritable bowel diarrhea, we'll use some medicines that help that, and there's actually a couple new medicines such as Viberzi that treat IBS-D. But avoiding medicines that make these conditions worse is just as important. If people have a tendency towards reflux, GERD, or ulcers, we'll avoid anti-inflammatories and aspirin and the like. So asking about the GI system is very important. We want to make sure that people are on a probiotic with advancing age. As we get older, we lose a lot of our good bacteria, and at least eating yogurt or the like, or taking a probiotic. I like people taking the probiotics. They tend to be more effective. Weight is an issue. Weight will guide where we go with medicine. If people are underweight, we can use certain medicines more commonly. If they're overweight or weight's a big issue, we avoid certain medicines. And there's a few that we use that might help with losing weight, such as topiramate, Topamax. We look at medicines. Did they cause weight gain in the person? We'll avoid those. Fatigue is a big issue. If you ask people with headaches what your biggest problem is, it's usually sleepiness, fatigue, they're tired, often chronically for months, years, or decades. So we want to avoid medicines that make fatigue worse, and there are a few headache medicines, stimulants sometimes certain antidepressants, that can help fatigue. But at the very least, we don't want to exacerbate and make tiredness worse. We look at functioning. How well are people functioning? Are they running and gunning, running a business, or are they at home in their parents' basement underfunctioning severely? There's a lot of underfunctioning adults. We try to work on functioning, move it along, but knowing the level of the person's functioning often helps. But how well people function and how resilient they are is often a very complex subject. It goes into genetics, modeling the first 15 years of life, psychological factors, and other factors. So we might have somebody where we can help their pain, but we don't help their functioning. But knowing the level of functioning is helpful. Exercise, we want to know how much people are exercising, what kind, and push people along towards averaging at least 20 minutes. Walkers do well. You don't need that much mild or moderate exercise to get 90% of the benefits of all exercise. We do push Pilates and core work, particularly with advancing age. People get in their 40s, 50s, 60s, 70s. Core work is helpful to prevent back pain. We really weren't meant to walk around on all twos. We were meant to walk around on all fours. Doing some core work helps prevent back pain in the 60s, 70s, 80s. I want to know what job people are doing or school requirements. If somebody is an accountant, for instance, in March heading into big tax season, I don't want to put them on Topamax, topiramate. It could make them spacey, or we might not want to use an antidepressant. So how much they have to function early in the morning. If they have to run and gun at 7 in the morning, I don't want to use a medicine at night, even if it helps their sleeping. That's going to make them so spacey and sedated early in the morning. High school is tougher to treat than college. College, they can get more sleep. They can take later classes. It's the high school years. Getting through high school is much more difficult. So knowing where they are in job and school helps. Social support, I want to really know who's at home, family, friends. There's a lot of isolation in our society. Can we de-isolate people? Can we get them to work part-time, volunteer? We want to get people out of the house and not be so isolated. It's not easy because of social media and the way our suburbs and our society is constructed. We have a lot of social isolation. Financial, it helps to know what somebody's financial condition is regarding can they afford the medicines, the therapies. I don't want to really suggest Botox if we know people cannot afford it at all. And certain medicines. Medicines have gotten too expensive. Even some older cheap generics are difficult to obtain. So I don't want to give people medicine that I know is going to cost $400 a month if they can't afford it. Resilience, I like to know the level of person's resilience, which is a very complex construct that we could talk a long time about. But how resilient people are depends on genetics, long arm and short arm of the serotonin gene. If people have two long arms, they're more resilient in general. If they have two short arms of the serotonin gene. Now this is not our arms, it's the arms of the gene and the DNA, etc. But if they have two short arms, it's not great. If they have abuse as a kid and they have two short arms of the serotonin gene, they're more likely to be a borderline personality or have many problems throughout life. Resilience is also modeled in the first 12, 15 years of life, and psychological factors enter into resilience. So you have a lot of people with severe chronic pain who work 70 hours and they run a firm, and then you have other people with more milder pain who are on Medicare disability at age 22. And it's all legitimate. I don't blame people for lack of resilience. We don't want to punish people for lack of resilience. It just helps to know. And we do use psychotherapy, etc., to try to slowly push people along towards being more resilient. Disability is a very complicated subject. Some people are disabled with their headaches, with just mild headaches. Some people have very severe headaches and a lot of other problems and are never on disability. We try to nudge people off of disability or have them work part-time if possible, but knowing why they're on disability often helps. I'm talking about acceptance. I want to know the level of acceptance. Acceptance is very important with a chronic illness. If people are constantly thinking that there's a magic cure for their headaches or their chronic pain, they're going to go to 100 different clinics looking for that cure. The road to acceptance is often littered with many stop-offs at various clinics or treatments looking for a cure. And at the end, people generally say, well, I have this chronic illness. It doesn't mean that I have to just do nothing about it. I can see doctors, take things, I can exercise, I can do meditation, I can see physical therapists, etc. But acceptance is very important, so we try to get what the person's level of acceptance. We also see lack of acceptance by proxy, I call it, where a mom will bring in her 16-year-old and say, how can a 16-year-old have bad daily headaches? So they don't have the acceptance. That increases the kids' anxiety also. So we try to dial down the angst and the anxiety about the chronic condition. Catastrophizing is very important. We try to dial down catastrophizing, have people not be so, when I ask what's the level of the pain daily on a 1 to 10 scale, and people say it's always a 14 out of 10, it's severe and the sky is falling and my life is over. We try to dial that down because that does kick up the anxiety. Cigarettes and alcohol, I want to know, are people smokers? How much? How much do they drink? History of addiction, which drug, how long ago? We want to not use addicting medicines if people had a problem in the past with certain drugs, although if they had a remote problem 20 years ago and it's a different drug, they may be able to take that drug. Family history of addiction is very important also. And significant others input. We look at what the spouse says, what the parent says. A lot of times, significant others will give us an insight into the person's functioning, into their reaction to pain, their psychological conditions much better than the person will. It's very crucial to look at significant others. And finally, our gestalt, our overall feeling about what's going to work for that person versus not work. What do your instincts say? Which medicines might work? What medicines won't work? Which ones should we eliminate? And you end up looking at all these factors that we've talked about in these two talks at a top 10 list for that person. This is number one, this is number two, and also a top 10 list for what should not be used. Avoid this, avoid that. Don't use this, don't use that. So everybody is different, everybody is unique. If you have 100 different headache patients, you're going to go 100 different ways. And it depends upon all these comorbidities and factors and response to medicine. About 50 items that we've outlined that go into our decision. Now a little bit about return visits. When people come in a month later, 2 months later, we can't reconstruct de novo from the start, the whole history. So we want to have prominently in the chart, consider this, consider that. We want to have these top 10 lists considered. When people come in with return visits, there's a lot to do. We need to go over their preventives, their as-needed abortives. We need to see their non-medicine aspects. Are they exercising? Do they need physical therapy? Do they have neck pain? Look at, do they want to have shots in the neck or nerve blocks or something like that? So there's a lot to do with people. And we need to assess for side effects to the preventives and the as-needed medicines. And, of course, look at outside of medicines. So the other problem is people who have come in a lot of times to a doctor often get grandfathered into certain medicines, and the doctor does not revisit, do they really need that medicine? Is it working? And you end up talking about factors that are not so crucial for the patient because it's more of a friendly visit. But it's very important if somebody comes in for the 100th time to look and assess their preventives, their as needed, where you want to go, as if they were a new patient. So I think I'll wrap it up here, and we're going to be putting more talks on, headache-related talks. Thank you very much.